Hey everyone, my name is Bailey McDuffie, and my educational innovation project is on blood culture collection and contamination. Blood cultures are a type of laboratory specimen that are collected when the patient has suspected bacteria or fungi in their bloodstream, which can also be referred to as sepsis. According to the World Health Organization, sepsis kills 11 million people each year, leaving millions of them disabled. The American College of Emergency Physicians reports that up to 40% of collected cultures are false positive, which can result in an extra 3 to 5 day stay, as well as up to an $8,800 cost for the patient. This means that the extra 3 to 5 days in the hospital with the additional $8,800 on the bill could be completely unnecessary, let alone harmful to the patient and their overall well-being. Blood culture results help to determine accurate antibiotic therapy, which can help prevent C. diff infections, decrease costs to both the facility and the patient, and result in shorter hospital stays. So just to give you some background on this project, I spoke with my preceptor, who is actually the ED director at my implementation site, about the potential project and need for this education. When I first spoke with him, he reported the department had a current contamination rate of 12.2%, which was the most recent monthly data reported at the time. The national goal, which is also the goal for the department, is no more than 3%. Just by this data alone, there was obviously a need for this education. But I went to the department staff for more information and to get their take on what was actually the issue. I sent a survey out via GroupMe to the 40 ED staff members at the implementation site and received 13 responses. The responses gave me a good indication that there was a need for education regarding the new customized kits they recently received, as well as the overall collection process. How to properly prep the insertion site, how to properly clean the bottle tops, which bottle to use with which insertion method, how much blood goes into each bottle, and how to label the bottles were a few of the inconsistencies among staff. Initial management of sepsis is usually started in the emergency department, so timely and sterile blood cultures are essential for a good outcome for the patient. In saying this, I decided to stay in the emergency department setting with a target audience of everyone who draws blood cultures. At the implementation site, this consists of paramedics, licensed practical nurses, and registered nurses. The constructivism learning theory guides this educational innovation by allowing participants to build upon knowledge and past experiences of blood culture collection. Another theory I felt needed to be acknowledged is the Lewin's change model. Blood culture collection is not a brand new skill that staff are learning how to do. A lot of it is just changing their practice and making it their new standard or new normal, if you will. For example, when cleaning the tops of the blood culture bottles, staff reported they would either leave the alcohol swabs on top until they took them off to inoculate the bottles, or they would just leave the alcohol swab on top while simultaneously inoculating the bottle. Both can lead to contaminated results. Evidence-based practice shows that the tops of the bottles must be cleaned and then left to air dry until inoculation. This is a new change that must be implemented into new practice to prevent contamination. With that being said, Lewin's change theory focuses on unfreezing, which is basically undoing something that has always been done, changing beliefs and feelings about the topic, and then refreezing to a permanent change and making it the standard. The project implementation started with a pretest to collect baseline knowledge and a short educational session about their new customized blood culture collection kits. The session was basically a brief introduction on the importance of collecting clean blood cultures, as well as an overview of how to use the customized collection kits. I was able to catch 38 staff members during these sessions, so 38 pretests were collected. Staff were given about 3 weeks to get used to the kits, and then were put through a simulation experience where demonstration return demonstration was utilized. As the educator for this project, I completed a demonstration as well as explained the importance of sterile collection and the negative impact false positive results can have on patient care. The staff then did a return demonstration and were able to apply new knowledge, change their practice, and verbalize the importance of clean blood culture collection. After the hands-on portion, staff completed a post-test and did an evaluation for the training. The pre-test and post-test will allow me to evaluate knowledge before the innovation and the knowledge after the innovation. A competency form was also used to check off each participant, which will be placed with the rest of their training records. The competency form was based off of the implementation site policy, as well as information from Lippincott and B.O. Murrow, who manufacture our actual blood culture bottles. I will be collecting the data for the month of September, so this part of the implementation had to be complete before the end of September in order to obtain an overall accurate monthly contamination rate. As I mentioned before, the goal for the department is a contamination rate of less than 3%, and the current rate is 12.2%. It's unrealistic for me to ask the department to go from 12.2% to less than 3% in 1 month, so my goal for this project is 8% for the month of September. Further sustainability of the project will eventually be the departmental goal of 3%. I do want to mention that on the post-test, an additional question was added to ask who would be interested in becoming a potential blood culture champion. The blood culture champions will be chosen from those who have a low contamination rate and show further interest in blood cultures. Check off to become a blood culture champion will consist of a blood culture collection on a real patient. If the staff member demonstrates clean preparation and collection, they will be deemed a blood culture champion and will be responsible for leading the department in continued low contamination rates. These champions will be chosen to lead the department and provide further education to those that are collecting the most contaminated cultures. The new way that staff were educated on how to label the blood culture collection bottles includes the user ID of the person who drew the sample in order to keep up with who was doing what. This way, the blood culture champions will know who in the department needs more education versus those who should be rewarded for their continued progress towards the departmental contamination goal. So that is the overview of my project. I hope I was able to make the needs, project plan, theoretical basis, and outcomes clear. So please let me know if there are any questions I can answer. Thank you for listening.